So we're going to be talking about state-of-the-art in treating massive and submassive pulmonary embolism. This is something that I've been thinking about since I was a first-year medical student and had a chance to work with Dr. Goldhaber, and it's really become somewhat of a passion for me and really my research focus and something that matters to me very much clinically. What we're going to do over the next 45 or 50 minutes, I want to leave some time for questions, is focus on our latest understanding of the epidemiology of pulmonary embolism. We're going to talk about pathophysiology and risk stratification of pulmonary embolism. And then we're going to apply evidence-based strategies to effectively manage massive and submassive PE. So this is a dramatic example of pulmonary embolism. This occurred in a 48-year-old woman that we took care of that was admitted with chronic obstructive pulmonary disease. She was doing very well on bronchodilators and antibiotics and was walking with physical therapy when she collapsed all of a sudden. There were attempts at resuscitation that were unsuccessful, and she was found to have this large saddle pulmonary embolism. In 2008, the U.S. Surgeon General estimated that 100,000 to 180,000 pulmonary embolism-related deaths occur annually in the U.S. alone, and that PE was actually the most preventable cause of death among hospitalized patients, more than catheter-based infection, actually PE. When we look at the incidence of venous thromboembolism at large, we see that it's increasing, and that's largely due to an increase in the number of cases of pulmonary embolism. These data from a Medicare cohort show that the rate of hospitalization for PE is actually on the increase across a number of demographic populations. And although we've made some inroads in improving mortality associated with pulmonary embolism, readmission for pulmonary embolism remains high. I don't want to paint too rosy of a picture. Although there have been improvements in PE-related mortality, the mortality associated with pulmonary embolism is still particularly high. From these data from the Italian PE registry, we see that pulmonary embolism in hospital mortality is almost 7%. And for our patients that present with the dramatic form of PE with hemodynamic instability, the mortality is almost a third. These data from the same registry are very important because they shatter a commonly held myth or belief that we propagate at our medical schools and on rounds, that patients don't actually die from pulmonary embolism. They die from whatever disease actually led to the pulmonary embolism, the cancer or the heart failure or the sepsis. But what we can see here that in the first 3 days after diagnosis of pulmonary embolism, patients actually die from PE. It's only if they survive that 72-hour window that they may go on to die from cancer or infection or heart failure. So now I want to talk a little bit about pathophysiology. We're going to talk about risk factors first and then about hemodynamics. So when we think of risk factors for pulmonary embolism, we can actually group them into different categories. Inherited risk factors include things like thrombophilias and family history. Lifestyle risk factors include smoking, stress, diet, obesity. There are acquired risk factors such as age, the presence of cancer, recent trauma, surgery, immobility, hospitalization, and then chronic medical illnesses, in particular chronic infections, things like COPD, heart failure can increase the risk. Chronic infection and acute infection, as well as things like inflammatory bowel disease or rheumatoid arthritis, increase the risk of PE, primarily through this concept of sort of chronic systemic inflammation. Here we can see that a number of very common diagnoses for admission to the hospital, to the medical service, actually are responsible for a heavy burden of pulmonary embolism and deep vein thrombosis. Things like heart failure, respiratory disease, pneumonias, cancer, stroke, myocardial infarction actually account for a high risk and a high number of cases of patients that present with PE or DVT. These data are very interesting. They come from a Danish health registry study. So in Denmark, when you're born or if you move to Denmark, they have this registry that keeps track of every interaction with healthcare. Every time you get a flu shot, every time you fill a prescription, every doctor's visit, every ED visit. And what they did was they looked at patients who had an initial venous thromboembolic event. It could have been provoked, it could have been unprovoked, but they looked at 30 years mortality compared with patients who never had a venous thromboembolic event. And what they were able to show is if you had an initial venous thromboembolic event, your mortality was increased for out to 30 years. So that really calls us to question whether our traditional view of venous thromboembolism as this time-limited disease that you treat for 3 to 6 months and then you can tell your patients they don't have to worry about it anymore probably isn't actually what happens. When you look at the causes of this long-term mortality, we see that recurrent pulmonary embolism is a very important cause of death in patients who've had an initial event. We may be able to gain some understanding from atherothrombosis research about why PE has such a high risk of relapse and why patients have adverse outcomes out to 30 years. First of all, atherothrombosis and venous thromboembolism share important risk factors, things like obesity, tobacco use, diabetes, stress, diet, and chronic inflammatory disease. But more importantly, there's actually shared pathophysiology, local and systemic hypercoagulability, local and systemic endothelial injury, and local and systemic inflammation. And it's this association that can lead a patient to 1 year suffer this massive pulmonary embolism that was removed during a surgical embolectomy, and then a year later present with inferior STEMI and have this large thrombus aspirated from their right coronary artery. We actually did a study, a histopathology study, focused on looking at inflammation in pulmonary embolism. We know that inflammation plays an important role in the development of pulmonary embolism in animals, but what we did here was take human pulmonary embolism specimens. We stained them first with a trichrome stain, which is a stain that highlights areas of organization or fibrosis. And you can see it doesn't represent very well on this screen, but in areas where there's sort of a bluish tinge, that's where there are areas of organization and fibrosis. Then we stained for CD11B, which is a neutrophil marker, and CD42B, which is a platelet marker. Now, traditionally in med school, we're taught that venous clot has nothing to do with platelets. It's all clotting factors. But here we can see there's dense staining for both neutrophils and platelets in this human PE specimen. Here we've stained in dark blue for myeloperoxidase, and we can see in the areas of fibrosis, there's actually dense staining for myeloperoxidase. And finally, in this last slice, we've stained for citrullonated histones. Now, citrullonated histones are a marker of something called neutrophil extracellular traps. This is something that was first really identified in animals as a response to sepsis. Actually, the neutrophil extrudes its DNA in long strands, almost like a net, in an effort to try to control the bacteremia and as a response to sepsis. And here in humans, we're actually seeing neutrophil extracellular traps in pulmonary embolism. And so we're seeing that in the normal pathophysiology of human PE, there is an element of inflammation. Now, there's a therapeutic correlate to this because there have been 2 pivotal studies in the last 5 years that have shown that antiplatelet therapy, which also has an anti-inflammatory component, can actually prevent venous thromboembolism after patients have had a first unprovoked event. We see here with low-dose aspirin, you can reduce the risk of recurrent venous thromboembolism, major vascular events, and provide a net clinical benefit. Even if we look at some pivotal trials looking at statin therapy for preventing cardiovascular disease, we see something very important. You'll remember Jupiter as a study that was looking at rosuvastatin in patients who had no history of cardiovascular events, very desirable lipids, but they had increased C-reactive protein. And in the main Jupiter study, they were actually able to show that rosuvastatin prevented cardiovascular events like myocardial infarction in these patients who, by all stretches, other than the high CRP, seemed to be low risk. Well, they didn't just look at atherothrombotic events, they looked at venous thromboembolism. And in a second paper, they were able to show that this statin actually decreased the risk of incident venous thromboembolism by 43%. And these patients had really normal lipids, so it's not through a lipid effect, and it's suspected that that's really through an anti-inflammatory effect. Now, there are two pivotal studies that are exploring this concept of modulating inflammation for prevention of cardiovascular disease. The first is CANTOS, which is a study of a human monoclonal antibody to interleukin-1 beta called canakinumab. This study's completed enrollment of 10,000 stable patients following MI who have an increased CRP, and they're looking at a pivotal secondary outcome of venous thromboembolism. The cardiovascular inflammation reduction trials, an NHLBI-funded study that we're enrolling in and helping to lead, and this is a study of low-dose methotrexate versus placebo in 7,000 patients with either stable MI or multivessel CAD and either type 2 diabetes or the metabolic syndrome. And again, this is a study looking at a secondary outcome of the rate of venous thromboembolism. If either of these two studies show that modulating inflammation can actually prevent venous thromboembolism, it'll dramatically change the way we look at both the pathophysiology and the treatment. Now to step away from that and to emphasize the pathophysiology from a hemodynamic standpoint, we have to understand that pulmonary embolism, the pathophysiology really depends on the right ventricle. PE causes an increase in pulmonary vascular resistance and RV pressure overload. This causes the RV to become hypokinetic and dilated, and that can decrease right ventricular cardiac output and can cause interventricular septal deviation towards the left ventricle. That decreases LV preload and left-sided cardiac output and can cause hypotension and decrease coronary perfusion. Now, this will lead to a decrease in RV myocardial oxygen supply at the same time as an increase in RV myocardial wall tension and an increase in RV myocardial oxygen demand. And it's this mismatch between supply and demand that actually can predispose patients to ischemia and even outright right ventricular infarction. Unfortunately, a subset of patients who suffer PE, probably 4%, but perhaps that's an underestimate, will go on to develop very debilitating chronic pulmonary hypertension, which we call chronic thromboembolic pulmonary hypertension, or CTEP. For some reason, these patients don't resolve the macrovascular obstruction of the PE, and on top of that, they have a persistent vasoconstrictor response. These two mechanisms result in pulmonary hypertension, pulmonary artery shear stress, in situ thrombosis, and a secondary small vessel arteriopathy that's very similar to what we see in idiopathic pulmonary arterial hypertension. Unfortunately for these patients, the mainstay of therapy is this exhaustive surgery called chronic pulmonary thromboendarterectomy. This is a true endarterectomy where patients have a sternotomy, they're put on bypass, they have intermittent circulatory arrest, all with the aims of scraping this very tenacious thromboembolic material from the pulmonary arteries. The surgeon has to get out into the branch vessels, and when they can achieve a very complete resection, they essentially remove a cast of the pulmonary arterial tree. And in the 50% of patients that are actually eligible for this surgery, it's a very durable and life-changing therapy. They return to their normal functional status. But really, we'd like to prevent patients from developing chronic thromboembolic pulmonary hypertension and other adverse long-term complications of PE. And so that's why we use risk stratification. One, to identify the patients who are going to be at risk for early adverse events, like in-hospital mortality, but perhaps also to identify patients who are in for complications down the line. First of all, we need to recognize that PE doesn't just describe one type of presentation. It's actually a spectrum of disorders. At one end of the spectrum, we have the really dramatic presentation of massive PE. That's about 5% of the PE population. These patients present with hypotension or syncope, cardiac arrest or shock or respiratory failure. And we know from experience that if we don't treat these patients aggressively, a very high proportion of them will go on to deteriorate and perhaps die. Submassive PE describes about a quarter of the PE population. This is where most of the consults to vascular medicine and cardiovascular specialists come. These patients present deceptively normotensive, and they may actually have very modest symptoms. But if we look closely, they have signs of right ventricular dysfunction or increased biomarkers, and a subset of these patients will go on to experience cardiovascular collapse or some adverse outcome. Fortunately for us, the majority of PE patients that we're going to see will present normotensive with normal RV function and will do very well with anticoagulation alone. One of the advances in risk stratification has been to use the very same data that we use to evaluate for PE to provide us with an assessment of right ventricular function and size. If we calculate an RV to LV diameter ratio over the axial images on the CT, we can actually get an assessment of right ventricular enlargement. When the RV to LV diameter ratio is greater than 0.9, that corresponds with RV enlargement and a 4 to 5-fold increased risk of early PE mortality. We can see here an example of a patient with an RV to LV ratio that's about 1, and then a more dramatic example where the RV diameter is about 5.2 centimeters and the LV diameter is about 3.2 centimeters, corresponding with severe RV enlargement. This was a meta-analysis that showed that the risk of PE-related mortality, if you have an increased RV to LV diameter ratio, may be as high as 7-fold. We're very used to using echocardiography, and certainly it's a very powerful tool for evaluating the right ventricle. Here we see some examples of what we can see in a patient with pulmonary embolism. This is a short axis view. We see here a large right ventricle, a very modest left ventricle, the interventricular septums being pushed or deviating towards the left ventricle. We call that almost a D-shaped left ventricle, and it's a sign of RV pressure overload. If we use transmitral Doppler, you'll remember I mentioned that RV pressure overload can impact LV filling. But if we look at transmitral Doppler, under normal circumstances, our LV filling is accomplished mostly through passive filling, and atrial kick, which is designated as an A wave on transmitral Doppler, is just a small component of filling. Well, that reverses in RV pressure overload. The E wave, which marks passive filling, is actually diminished, and we're more dependent on atrial kick, the A wave, and so the normal tall E to short A is reversed in RV pressure overload, and we see that we have a much taller A wave. Diagnosing RV dysfunction in patients with pulmonary embolism by echo is very important. When we see RV hypokinesis in PE, patients have a 90-day mortality that approaches 21%. But it's very important. Look at the patients who have normal RV function with PE. That 90-day mortality is 15%. What do you think the 90-day mortality is for ST elevation myocardial infarction? It's about 7 to 9% with our current techniques and our current era of reperfusion. And we rush those patients to the cath lab as fast as possible. We actually keep track of the amount of time that it takes to get them there. But PE, with a higher 90-day mortality, we're very hesitant to do anything aggressive. We hem and haw and talk about it, but it has a higher mortality. Something to think about. The troponin provides us with incremental information over the echo. Whether you have RV enlargement or not, increasing levels of troponin correspond with a higher rate of pulmonary embolism death and all-cause mortality. Something that I find particularly helpful is the 2014 European Society of Cardiology guidelines for risk stratification of acute PE. I like these guidelines because they teach us to actually use all of the tools that we have at our disposal for risk stratification to create a gestalt of whether patients are going to be at risk for adverse events. Low-risk patients are very easy to identify. They have normal hemodynamics. If you do a pulmonary embolism severity index, which is a bedside score, it's low. And if you look for signs of RV dysfunction or positive biomarkers, they're normal. Likewise, high-risk patients are very easy to pick out. They present with hemodynamic instability. You don't really need to look for troponins or for echocardiography or CT. Then there's this middle group of intermediate risk patients, which actually can be divided into two categories. Intermediate low-risk patients have normal hemodynamics, but they have a high pulmonary embolism severity index. And if you look at RV or cardiac biomarkers, one of them's abnormal or none of them are abnormal. Intermediate high-risk patients, again, normal hemodynamics, pulmonary embolism severity index is abnormal, and they have both signs of right ventricular dysfunction. They have positive biomarkers, and they have imaging evidence of right ventricular enlargement or dysfunction. And for the first time in a set of guidelines, the European Society actually recommends in intermediate high-risk patients that you consider reperfusion therapy. Before we get into reperfusion therapy, I want to talk about anticoagulation, because no matter what category the patient fits into, anticoagulation is going to be the cornerstone of therapy. It needs to be instituted immediately, and it needs to be effective. So which immediate anticoagulant we use depends on what our plans are for the patient. If we're thinking about doing advanced therapy, such as systemic fibrinolysis, a catheter-based pharmacomechanical approach, or surgical embolectomy, then we'll use unfractionated heparin so we can control anticoagulation, stop it if there's a complication. For patients that are only going to require anticoagulation, we have more options now than ever before. We have a number of injectable agents, and we have the non-vitamin K oral anticoagulants. If there's a worry about heparin-induced thrombocytopenia, then we can use direct thrombin inhibitors. One of the major advances in PE therapy has actually been the arrival of the non-vitamin K oral anticoagulants, or NOACs. I'm not going to go through every trial because I think this meta-analysis very nicely summarizes the advances that the NOACs have given to the field. First of all, the NOACs appear to be very comparable to warfarin for efficacy when we look at outcomes such as recurrent venous thromboembolism or VTE-related death. Where they really shine, though, is in safety, with dramatic reductions compared with warfarin in major bleeding, clinically relevant non-major bleeding, non-fatal intracranial hemorrhage, and fatal bleeding. I will call your attention to one study, Hokusai VTE, which evaluated edoxaban versus warfarin in patients with venous thromboembolism. We do see what we have come to know as true from the meta-analysis, non-inferiority compared with warfarin for edoxaban when we look at an endpoint for efficacy of adjudicated recurrent VTE, and superiority when it comes to bleeding, in particular major and clinically relevant non-major bleeding. But what's particularly interesting, in almost 1,000 patients with PE and RV dysfunction, what we would call intermediate risk or submassive PE, in the patients who received edoxaban, the risk of recurrent venous thromboembolism was cut in half compared with warfarin. So the NOACs, or in particular this agent, may have some particular benefit to patients with a higher risk PE. Our anticoagulation has really been in a state of evolution. For decades, we were restricted to one avenue of anticoagulation. It was bridging. It was giving a parenteral anticoagulant like heparin or an injectable as a bridge towards warfarin with an INR of 2 to 3. But now we have two additional avenues for anticoagulation. We have switching, where we give a parenteral anticoagulant like low molecular weight heparin or unfractionated heparin, and then just convert over to dabigatran or edoxaban. And we have completely oral monotherapy, where patients don't need to have an IV. They don't need to give themselves injections of an anticoagulant. They simply take a higher dose of rivaroxaban or apixaban for a period of time and then switch over to a maintenance dose. And this has the potential to really facilitate getting patients out of the hospital after diagnosis of VT and perhaps even having them discharged from the emergency department if they're low risk. The 2016 CHEST guidelines actually for the first time recommend using the NOACs over warfarin for patients with venous thromboembolism. One of the big challenges is after we treat patients for PE in the acute phase is keeping them from presenting with recurrent events. We have this concept of determining the optimal duration of anticoagulation, which actually becomes a high source of referrals to cardiovascular medicine. We know patients who've had provoked events oftentimes can get by with just short-term therapy of 3 to 6 months, although like I showed in that Danish study that include provoked and unprovoked patients, the risk actually is not zero even if it's a provoked event. Cancer patients need long-term anticoagulation. Usually we do that with a low molecular weight heparin, and we do it as long as the cancer is active because the risk of recurrence is very high. Patients with unprovoked venous thromboembolism have a very high risk of recurrence. I'm going to show you some data on that. And if the risk of bleeding is low, we recommend long-term indefinite anticoagulation. Unfortunately, sometimes patients fall into this gray zone where it's indeterminate what their risk might be, and we have to use other clinical risk factors to make decisions about the length of anticoagulation. Here we can see the data that showed that if you have an idiopathic or unprovoked venous thromboembolism, your risk of recurrence at 10 years exceeds 50%. And that's why we oftentimes recommend extended anticoagulation. But let's not be fooled. If we look at patients with secondary or provoked venous thromboembolism, the recurrence rate at 10 years is as high as almost 25%. And it may be in the future that we start to think of even provoked venous thromboembolism as a chronic disease that needs to be treated long term. The good news right now for our patients with unprovoked venous thromboembolism is whether we prescribe warfarin at a low intensity of an INR of 1.5 to 2 or a full intensity of 2 to 3 or one of the NOACs, we can offer our patients a 60 to 90% reduction in VTE recurrence with extended therapy. And that's regardless of whether they have a thrombophilia. Here we can see the important observation that patients who have VTE in the setting of cancer have a very high risk of recurrence compared to those who have VTE and do not have malignancy. It's a threefold increase. This was the driver between a very pivotal study that's now more than a decade old called the CLOT trial, which showed that if you used a low molecular weight heparin-based regimen as monotherapy without any transition to warfarin versus warfarin, you could actually reduce the risk of recurrence by half. This was more recently reevaluated in a trial called the CATCH trial, looking at tinzaparin, another type of low molecular weight heparin, and again, very similar findings where there seemed to be a lower risk of recurrent venous thromboembolism without increasing the risk of bleeding compared with oral therapy. What about the NOACs for patients with cancer? It's very difficult to tell your patient with malignancy that on top of all of the discomfort of the cancer and their chemotherapy, that once they've developed a VTE, now they have to start giving themselves twice daily injections subcutaneously. Wouldn't the NOACs be such an advance for these patients, even just from a comfort level? Well, unfortunately, the pivotal trials looking at the NOACs for VTE did not include a large number of patients with cancer. In meta-analysis, it certainly looks like the NOACs may be favorable compared with warfarin, but we need more data, and there are randomized controlled trials underway comparing the NOACs to warfarin and also to low molecular weight heparin. Certainly, this would be a major advance for our cancer patients. When it comes to selecting the optimal agent for extended duration therapy, first we ask ourselves, does the patient have cancer or not? If they do, we really want to focus on a low molecular weight heparin monotherapy regimen until we have more data about the NOACs. If they don't have cancer and they're non-high bleeding risk and willing to continue anticoagulation, a NOAC and either low or normal intensity of warfarin would be a very good option. For patients that are high risk for bleeding and not willing to continue anticoagulation, we could consider that low-dose aspirin, although it only provides a 30% risk reduction. Or we could try low-dose apixaban, which in Amplify extension actually showed to have a bleeding rate similar to placebo with very high efficacy. Having the NOACs, because they're very specifically targeted in the case of dabigatran to thrombin inhibition, in the case of edoxaban, apixaban, and rivaroxaban to inhibiting factor Xa, gives us the opportunity to actually make targeted antidotes. In the case of dabigatran, there's an FDA-approved reversal agent called idarosizumab, or Praxbind. This is a monoclonal antibody that actually looks very similar to thrombin, which is what dabigatran binds to. So it binds to the Praxbind with high affinity, but the monoclonal antibody has no effect on coagulation. So it just essentially inactivates dabigatran, reverses anticoagulation without really tipping patients towards a hypercoagulable state. That's FDA approved, and most medical centers have access to it. For the direct 10A inhibitors, there's andexanet alpha, which is currently under further FDA review. This is a recombinant modified factor 10A mimic molecule. It looks very much like factor 10A, but has no activity, and it binds with high affinity to the NOACs. And hopefully we'll have availability of this within the next year. So for managing bleeding in patients who are on NOACs, if they're on dabigatran, we can give activated charcoal if the ingestion's within 2 hours. You can also dialyze dabigatran. And then you can provide idarosizumab, which is given as a 2.5 gram bolus, given twice, and it's extremely effective. For the direct 10A inhibitors, until we have approval of andexanet alpha, you can use 4-factor prothrombin complex concentrate, which is called Kcentra. So now we're going to talk about advanced therapies. And these are the therapies that we select in patients in whom anticoagulation just isn't going to be enough. We have fibrinolysis, we have catheter-based therapy, we have surgical embolectomy, and we have IVC filters. The promise of fibrinolysis is that it can prevent mortality by reducing RV failure, by preventing hemodynamic collapse. It may reduce RV pressure overload by rapidly resolving the obstruction of the pulmonary arterial tree and reducing these circulating pulmonary vasoconstrictors. It may prevent recurrent PE. We know that many patients who suffer PE have residual thrombus in the pelvis or lower extremities, and systemic fibrinolysis will actually help to resolve those. We also hope that it improves gas exchange by increasing pulmonary capillary blood flow. A meta-analysis that was published 2 years ago was really instrumental in showing something that many experts held to be true for decades but could not prove in individual randomized controlled trials, that fibrinolysis actually saves lives. In this meta-analysis, we see that that actually is true, that fibrinolysis compared with anticoagulation alone reduces all-cause mortality, and it probably does that by preventing recurrent PE. Unfortunately, this efficacy comes at a very important cost, and namely major bleeding and intracranial hemorrhage. We can see even if we restrict the meta-analysis to submassive pulmonary embolism, there's still a very important mortality benefit with fibrinolysis. That meta-analysis was very much driven by the most recent and largest fibrinolytic trial in pulmonary embolism to date, which was called Pytho. Pytho is the Greek goddess of persuasion, and the designers of this trial were really focused on convincing naysayers that this could actually impact hard outcomes. Well, they were able to show with tenecteplase, a fibrinolytic, a reduction in hemodynamic collapse, which is a clinical outcome that I think we could all get behind. The problem is they also noticed an increase in hemorrhagic stroke with fibrinolysis. We conducted our own analysis of major bleeding in the setting of fibrinolysis, not in the tightly controlled, randomized controlled trial setting, but in the real world, the patients that we saw at Brigham that we gave fibrinolysis to, and we were very sobered to see that in 104 patients, 20 had major bleeding, 1 patient had a fatal intracranial hemorrhage, 1 patient required surgery to stop the bleeding, and 7 patients had bleeding in excess of 3 units. On top of that, almost 50% of the time, we can't identify the source of bleeding. It's just a drop in hematocrit. But you can see here that we observed a 5% intracranial hemorrhage rate in the real world. This is an example of something that I personally caused. It's an ever-present reminder of how careful we have to be with prescribing systemic fibrinolysis. This was an elderly woman that presented to the Brigham with submassive pulmonary embolism. She was profoundly hypoxemic and very short of breath. She had no contraindications to fibrinolysis, but we thought if we could institute anticoagulation and if she would improve over 24 to 48 hours, we might be able to avoid having to do any advanced therapy. Or the patient and her family weren't certain they really wanted anything that aggressive. So we gave anticoagulation. We had very therapeutic PTTs on heparin, but at 48 hours, she was still very hypoxemic, and walking to the bathroom was quite a chore for her. So we felt that we had to do more. On echo, she still had RV dysfunction and high pulmonary arterial systolic pressure, so we gave her systemic fibrinolysis. And about an hour into the infusion of 100 milligrams of TPA, she developed a very bad headache. And so I sent her for a CT scan, stopping the TPA, and I hit refresh on our radiology viewer every second trying to bring up that CT. And as soon as I saw this left cerebellar bleed, I knew exactly what had happened. And this is a very important reminder of even when you screen patients very carefully, you can have bleeding events with systemic fibrinolysis. She did very well. She did not need neurosurgery. She just spent some time in the neuro ICU. This fear of causing bleeding is what has really driven interest in alternative techniques for achieving reduction in RV pressure overload. Catheter-based techniques have the potential to avoid the high risk of major bleeding associated with systemic fibrinolysis because they use a lower dose of fibrinolytic drug. You may get more complete thrombus resolution because you're directing the fibrinolytic at the area of highest thrombotic burden. And it may be more effective for subacute thrombus because you're combining not just pharmacological therapy, you're actually mechanically changing the thrombus. One of the catheter-based techniques that's been best studied is the ECHO system of ultrasound-facilitated catheter-based fibrinolysis. It's a 2-catheter system. There's a drug delivery catheter with regularly spaced microscopic side holes that deliver the fibrinolytic drug. And then there's an inner core catheter that has regularly spaced ultrasound transducers that produce a low level of ultrasound, such as you might use in obstetrics or to diagnose a DVT. Here we can see the catheter has been placed directly into the pulmonary embolism. We see the TPA coming out of the side holes. The ultrasound component is believed to introduce 2 mechanisms to facilitate fibrinolysis. The first is something called acoustic streaming, where these wavelets actually help to propagate the TPA into the pulmonary embolism. And then there's something called thrombus conditioning. Under usual circumstances, fibrin is arranged in a very tight lattice and the fibrin strands are very thick. Under the influence of ultrasound, the fibrin strands thin and pull apart, and this is believed to actually open up more binding sites for the TPA. This was first studied in a European randomized controlled trial called Ultima, which looked at the ultrasound-facilitated catheter-based fibrinolytic procedure versus heparin alone. They used a surrogate endpoint of RV to LV diameter ratio, which I showed you was a powerful surrogate for PE mortality. And they were able to show a dramatic reduction from baseline to 24 hours in patients who received the ultrasound-facilitated catheter-based approach compared with anticoagulation, although at 90 days it did appear that the anticoagulation group caught up. For safety, you really couldn't ask for better. There were no deaths in the procedure group, 1 in the heparin group, no recurrent venous thromboembolic events, and no major bleeding, including no intracranial hemorrhage. We were charged by the FDA, if they were going to approve this device in the US, they wanted a trial that was going to provide more robust safety data. So we designed and executed the Seattle 2 trial, which was a single-arm prospective study looking at patients with massive or submassive pulmonary embolism. They had to have symptoms of 14 days or fewer, and they had to have RV enlargement on the CT with an RV to LV diameter ratio of 0.9 or greater. Patients received ultrasound-facilitated catheter-based fibrinolysis if they had unilateral disease with one catheter providing 24 milligrams of TPA. If they had 2 devices to treat bilateral disease, then they got 1 milligram per hour for only 12 hours, so that all the groups just got 24 milligrams total of TPA. Follow-up was done at 48 hours with a CT to measure the change in RV to LV diameter ratio, and then an echo to look at pulmonary artery systolic pressure. We were able to show in our primary efficacy outcome a 25% reduction in the RV to LV diameter ratio from before the procedure to 48 hours after the start of the procedure. Here we can see a very dramatic example. Before the procedure, the patient has a very dilated right ventricle and a very small left ventricle, giving an RV to LV ratio of 2.5, among the largest that I've seen. And then post-procedure, we see that the right ventricle has decompressed a bit, the left ventricle is re-expanded, and now that RV to LV diameter ratio is normal. We also assessed pulmonary angiographic obstruction using something called a modified Miller index. And we were able to show a 30% reduction in the obstructive pulmonary embolism from pre-procedure to 48 hours after the start of the procedure. Here's another dramatic case where you see dense filling defects here on the right and on the left. And after the procedure, those areas have been completely recanalized. Likewise, we showed a 30% reduction in pulmonary artery systolic pressures from pre-procedure to post-procedure, and that held true at 48 hours as measured by echocardiography. When it comes to safety, we observed a 10% risk of major bleeding, but we had a very inclusive, very liberal diagnostic criteria for major bleeding. We used gusto severe of life or life-threatening along with gusto moderate to signify major bleeding. Only one patient had a gusto severe bleed. The rest were gusto moderate. Gusto moderate essentially is a bleed that requires a transfusion. And intracranial hemorrhage, no cases. We didn't observe a single one. So to put things in context, if we look at traditional registries like the International Cooperative PE Registry, in patients who got fibrinolysis, they had a rate of intracranial hemorrhage of 3%. In Pytho, which was this almost maniacally controlled study where only the very safest patients were selected to get fibrinolysis, the risk of ICH was still 2%. And in Seattle 2, we're actually to really overcome this hurdle of intracranial hemorrhage with no intracranial bleeds. Recent study looked at the nationwide inpatient sample, which is a very large database, to look at differences in outcomes with catheter versus systemic fibrinolysis. And it's a very nice study showing that catheter-based approach may provide some benefit in regards to in-hospital death and a composite of in-hospital death and intracranial hemorrhage. One of the criticisms of a catheter-based approach is that it keeps patients in the hospital for longer. That doesn't really seem to be true, although it is more costly. The CHEST guidelines recently published for 2016 still take a somewhat of a hands-off approach when it comes to catheter-based fibrinolysis. Only in patients who have a high bleeding risk and can't get systemic fibrinolysis, or those that failed systemic fibrinolysis, or in shock and they think you can't actually give systemic fibrinolysis fast enough, they suggest catheter-based thrombus removal versus no such intervention. In clinical practice, we tend to reach for catheter-based fibrinolysis a little more often than this would suggest. We're currently in the late stages of Optilice PE, which is a follow-up trial to Seattle 2, really designed to tackle some unanswered questions from that initial Seattle 2 trial. Can we lower the fibrinolytic dose further to improve safety without compromising efficacy? And can we speed up the procedure so that we don't keep patients in the CCU for 12 to 24 hours? This is a 150 patient study on submassive PE with 3 actual dosing arms, and we're looking at a change in CT-determined RV to LV diameter ratio, the Miller index, something called treatment success, and then major bleeding at 72 hours. And we hope to be able to have those data within the next year. Now I want to share with you something very interesting that we're exploring with the company that produces the system. We have a proprietary non-contrast CT technique for creating 3D reconstructions of the pulmonary vasculature, where we can actually see the small 1 millimeter vessels. It's not, one of the main questions about the echoes procedure is, where does it actually really work? We see some patients who get the ultrasound facilitated catheter-based procedure that don't have really that dramatic debulking of the proximal clot. There is improvement, but it's not all gone, and yet their RV dramatically improves. Where's that change? Well, we've done a few preliminary studies using this technique that we have at the Brigham, and you can see here that pre-procedure, this is perfusion to the pulmonary vasculature. You can see that following the procedure in a PE patient, now there's much more of a increase in the density of these small 1 millimeter vessels, which are the dark red vessels. It's like almost blushed or bloomed in the periphery of the vessel. And what we can see is that from pre-procedure to post-procedure, where there's an increase in blood flow is not in the proximal vessels, but actually in these smaller vessels, these 2 millimeter, 3 millimeter vessels. You can see here in vessels that are 5 millimeters or smaller, there's an increase of blood flow of over 70%. Here we can see in the larger vessels, there's less of an increase in blood flow. The change really seems to be actually in the small vessels. The fibrinolytic approach is doing something to increase perfusion to the small vessels. That's why perhaps we see patients respond clinically so quickly when maybe the clot doesn't change, at least on a follow-up CT, as much as we'd like. You can see here there's a dramatic improvement in RV volumes. We can actually calculate RV volumes, which is actually what we're trying to estimate with RV diameter, is actually a sense of RV volume, and we can actually calculate RV volume using this non-contrast technique. Here's another example. You can see here from pre-procedure to post-procedure a large increase in the small 1 millimeter vessels, the red vessels. You can see the larger vessels, these blue ones that are over 6 millimeters, they actually look a little bit decompressed in the post-procedure imaging. And we see once again, we've increased flow to the small, very peripheral vessels without much of a change in the more central vessels, and yet we've still had a 50% reduction in RV volume, suggesting that it's not really debulking the proximal clot like you might see in an embolectomy. This is actually doing something to the peripheral vasculature. And we're going to be exploring this in our Seattle 2 data set. This is an example of a patient that had symptoms for much longer than 2 weeks and underwent the catheter-based procedure. And there's not much of a difference in the reperfusion. And accordingly, because there isn't much of a difference in reperfusion of the distal vasculature, there's not much of a change in the RV volume. A word about pulmonary embolectomy in patients that can't receive any fibrinolytic drug, and that's about 50% of the PE population that we see will have some contraindication even to low-dose fibrinolysis. We can consider surgical pulmonary embolectomy. We recently published a series of 115 patients with one of our younger cardiac surgeons and have shown for the first time a marked improvement in what used to be considered a very surgery associated with very high mortality. We can see now that the survival rates operatively at 6 months, 1 year, and 3 years are better than any historical measures for both stable and unstable PE. This is a great example of a patient that I saw at our center 2 years ago. It's a guy with an infected hip prosthesis. He had that removed, and then kept spiking fever, so they continued to give him IV antibiotics in-house. He was there for about 3 weeks and then was ready for discharge. He was signing his discharge paperwork when he became profoundly dyspneic, hypoxemic, and tachycardic. Went for a CT scan that showed this saddle pulmonary embolism and signs of right ventricular enlargement. We all felt he was too close to surgery to really safely receive any fibrinolytic, and so we sent him for open surgical embolectomy. You can see this DVT that's intact that was removed from the pulmonary arteries. IVC filters should really only be used in patients that have a contraindication to anticoagulation or in whom there's failure of therapeutic anticoagulation with a recurrent event. Unfortunately, we have this habit of putting in a lot of filters for patients who are safely anticoagulated, but we're just really worried that if they have a second event, they might collapse or die. So we put in a filter, probably more for our own comfort than for any real benefit. And I say that because if we look at PREPIC 2, which was a study published last year, they took patients with PE who had some additional marker for an adverse outcome, and they randomized them to anticoagulation plus or minus an adjunctive filter. And they weren't able to show any reduction in pulmonary embolism or any reduction in mortality at 3 or 6 months. So we really probably should not be using filters in this way. There may be some very high-risk patients in whom we should be using it, but not in patients who, in general, can be anticoagulated safely. One of the problems with advanced therapy for PE is that we have 3 sets of guidelines, a burgeoning number of advanced techniques, and it can be very challenging for clinicians to actually interpret how to use these technologies and when to use them. For massive PE, if we look at the AHA guidelines, it's reasonable. The CHEST guidelines say advanced therapies like fibrinolysis are suggested, and the ESC say it's recommended. So for massive PE, at least we're almost all on the same page. For submassive PE, it gets very confusing. The AHA says, okay, you need to have severe RV dysfunction or major biomarker elevation. The CHEST guidelines say, figure it out. Be a doctor. Figure it out. The ESC says, look for RV dysfunction and biomarker elevation. And that's a little bit more helpful. But it's still a big challenge. And because of this challenge, there's been tremendous interest in multidisciplinary PE response teams that merge the expertise of different providers that have something to add to the care of a patient with PE. So if you have a patient in the emergency department who has PE and the team there is unclear as whether they should provide advanced therapy or not, they can activate this PE response team. A clinician on call will come to the bedside, evaluate the patient and the imaging and the labs. They'll set up a conference with representatives from vascular medicine, interventional cardiology, cardiac surgery, vascular surgery, radiology, whoever at that medical center wants to be involved in a team like this. There'll be discussion and consensus, and then the options are presented to the patient, family, and care team, and then you can facilitate access to things like surgical embolectomy or catheter-based embolectomy. MGH published their early experience having a pulmonary embolism response team. In the 30% of patients that were low risk, patients got anticoagulation and did very well. The submassive PE patients, that's about over 50% of their consults to the PERT team, still most got anticoagulation and survivorship was excellent. But in the 16% of patients who had massive PE, there was really a smattering of different techniques that were used, including ECMO, and survival was only 50%, really suggesting that we have a long way to go still at taking care of our very sickest PE patients. More recently, they published a series of almost 400 PE response team activations. Still most of their volume submassive, but they did get a higher percentage of massive PE patients. 11% of PE patients were treated with systemic or catheter-based fibrinolysis, but still most got anticoagulation alone. Hemorrhagic complications were rare overall, especially with patients treated with a catheter-based approach. And the all-cause mortality for PERT patients with confirmed PE was 12%. So still a high mortality. We still have work to be done. So in summary, Risk stratification is critical for identifying P patients who may benefit from advanced therapies. Selection of advanced therapies and anticoagulation strategies really depend on assessment of the patient's risk of adverse outcomes, major bleeding, and also the patient's preferences. And then multidisciplinary PE response teams have the potential to standardize PE care and improve access to advanced therapies. We're still in the early stages and still understanding what impact these teams could actually have. And with that, it's been an absolute delight to talk to you this morning about PE, and I thank you very much for your attention.
So first of all, we are being recorded, so let's go ahead and use all the microphones. I think this one's not on. So
Okay.
Thanks, Greg.
Yeah, no problem.
Zina Safdar, I'm a pulmonologist.
Great.
So excellent presentation. Thank
you.
you for giving this excellent overview. So my question is, how many of these patients with acute PE or subacute PE go on to develop chronic PEs?
Mm-hmm. Yeah.
Because I know that you have a very robust
Yes.
CTES program by Rich Janik.
Yes, yes.
Yeah.
So it's estimated to be about 4%, but we believe that to be an underestimate. And there's the potential that it could be a gross underestimate, because one of the common observations in chronic thromboembolic pulmonary hypertension is that many patients actually don't give you a history of having had a PE. They present with pulmonary hypertension, and they have chronic thromboembolic pulmonary emboli on their CT, but they don't have a history of presenting with pulmonary embolism. It appears that some patients have missed PE and they go on to develop pulmonary hypertension. So it may actually be more common than we think, but the hard number now that we use is about 4%.
Is there any prospective trials looking at that?
So we tried to work on a registry with Rich and Vic Tapson, who also is very active in the pulmonary community looking at pulmonary embolism. And we're still trying to work out potentially a prospective registry to better quantify what the incidence of CTEPH is. As of yet, we don't have anything that's going to provide those data in the near future. Yes, sir.
Enjoyed your talk. Carlos Vichara, I'm a vascular surgeon here. I have two questions for you. One, you presented that patient with, doing okay, but kind of short of breath, just walking to the bathroom. And this is, I think, the most difficult patient. I personally believe that we're hard for us to make a decision to treat, especially since, despite the data you showed, with a 30-day 90-day mortality, but also anticoagulation, if they do well, eventually they will catch up.
Correct.
And the bleeding, I personally have two patients with intracranial hemorrhage. One did not survive, one survived after craniotomy. So anything else that you would, in your algorithm, that you would add to kind of decide, okay, this patient on a little bit of, 6, maybe 5 liters oxygen, hang in there. The problem is if you take it to procedure, you intubate them, and then I feel like it's a spiral path. So if you can shed some light on
Sure.
how you choose that patient. My other question is on, you showed that CT scan with the imaging, which is beautiful. The problem with the ECOS is that you're putting one catheter on one side, and you might have clot everywhere. And I can tell you on the left side, the catheter, that wire always goes in the left inferior pulmonary artery, pulmonary vein. And then the question is, can you tell from that imaging where you should target your ECOS catheter to place it for better treatment?
So I'll do the second question first. Usually you can tell where to place the ECOS catheter from the CT. You don't need that advanced 3D technique to do that. It's very interesting, though. We see changes in the distal vasculature even in the other side when patients have just unilateral major disease. They may have some chronic or some acute, very distal subsegmental PE on the other side. We still observe that change. There's something that happens systemically in the lung that isn't just limited to the side that's being treated with the ECOS catheter. With regards to other things that we use to make the decision of whether we apply advanced therapies, I think in patients who are profoundly symptomatic, patients who have very severe pulmonary hypertension, patients who have persistent hypoxemia, those are other reasons that we might use. We do sometimes in patients that are just on a few liters, give them a trial of anticoagulation if they don't have very severe signs of RV dysfunction to see if they get better before we have to do anything advanced. We will do that. And a good proportion of them will go on to do fine.
And biomarkers too? I mean, do you really use them?
So we use troponin. The BNP actually hasn't really been evaluated in a prospect. It's all post hoc analyses, so we don't think that's as robust as the troponin data. So we tend to exclusively use troponin. Yes. Yeah.
Excellent talk. Ashit Gohar, one of the heart failure transplant cardiologists. Are there any trials looking at low-dose thrombolytics in submassive P, systemic low-dose thrombolytics?
So there have been a number of trials looking at that. There was one called MOPIT, and there was one called the Chinese VTE study, looking at 50 milligrams of TPA given. And those trials were able to show, for surrogate endpoints, usually pulmonary hypertension, a good response to systemic low-dose fibrinolysis compared with either systemic full dose or with anticoagulation alone. The issue is the small numbers, and none of the guidelines have really picked that up as something that they recommend. Some centers do it. We tend not to use it because if we're going to give a low dose, we want to give an even lower dose through a catheter-based technique.
So I mean, just extrapolating from our pump thrombosis data, we've developed here a low-dose thrombolytic protocol where we do just 18 milligrams over 6 hours every day for 5 days. And I mean, granted, the efficacy is not 100%, but
Right.
pump thrombosis is a different beast altogether.
Right.
But what we have seen is that there is zero intracranial hemorrhage, but efficacy is about maybe 65–70%. So I just wanted to know your thoughts on. But we do it for 5 days. So
Yeah, and so 5 days continuously, or just 6 hours
no,
for
6
5
hours
days?
every day.
Yeah.
Overlapped with heparin.
Yeah. So I mean, I think that's a very when you look at using fibrinolytic, what you really want to avoid is the intracranial hemorrhage. If you can provide benefit to the majority of patients, maybe not all of them, but the majority, then that's a winning situation. Yes, sir.
It's a little bit of a retro question.
It's okay.
Except in dramatic presentation, somebody goes to the washroom, Valsalvas, and collapses. Has anybody ever looked at how the diagnosis of pulmonary embolism is made, whether it's made from history, whether it's made from physical exam, listening to the second heart sound, whether it's made from imaging as a final common pathway is what the heck's going on with this patient?
You mean as prognosis, if you can diagnose it on history or?
Well, how do people make a diagnosis?
Sure.
Has anybody ever looked at that?
Yeah, so pulmonary embolism was widely known as a challenging disease to diagnose that was often missed and only picked up on autopsy until CT was really incorporated widespread. The history doesn't seem to be particularly helpful. A lot of the symptoms that patients describe with PE are very nonspecific and could be the same symptoms that you would encounter in heart failure, the same symptoms that you might encounter with pneumonia. Where the things that are very helpful in the history are things like immobility, a prior history of major surgery or major trauma, that can point you in the direction of pulmonary embolism, but largely the history is not that reliable. Things like the second heart sound, RV heaves on physical examination also are very nonspecific and don't necessarily point you in the direction of pulmonary embolism. The ECG may show you signs of right ventricular strain with the McGinn-White pattern, the S1Q3T3, or anterior T-wave inversions. But again, nonspecific. You can see anterior T-wave inversions with myocardial infarction. You can see an S1Q3T3 in pulmonary hypertension. So the EKG doesn't help. The chest X-ray doesn't really help. All of these named signs, the Westermarck sign, the Hampton's hump, the Pallas sign, they're not really as specific, and they're not commonly found. The CT seems to have really been the major advance forward for diagnosing PE. VQ scans, which were used prior to CT, did have a reasonable role, but the limitation was that most often you got an indeterminate read or an intermediate risk scan, and you still weren't sure that there was a PE. So it's really been CT that is the real advance for diagnosing PE. Yes? I think they're quite a fan of the microphones.
The CT scan was actually non-contrast, you said?
For our technique, it's completely non-contrast.
Greg, how late is too late for thrombolysis? Especially like cases we have PERT teams just
Yep.
turning down
Yep.
a case for thrombolysis, and then patient's not doing well or patient changed their mind. How late you can just reinitiate the...
So it's actually been looked at. There was a study looking at fibrinolysis and measuring the response by VQ scan. And after 2 weeks of symptoms, the response to fibrinolysis is greatly attenuated. If you can do it before 2 weeks of symptoms, you get a very nice response in reperfusion. After 2 weeks, you may not see much. That's with systemic. Things like catheter-based approaches that add a mechanical component may buy you some more time.
So I just have one quick question. So thinking about the real salvage patients, by the time I'm seeing Brian here, so I'm inspired to ask this question. By the time you get to ECMO
Right.
at that point in time, what do you think is really your outcome at that point in time? Or at least what's been your experience? I mean, by the time you get to that
Right.
salvage rescue, how often do these patients, in your experience, are coming back?
It's disappointing, and it's really been some of it's unfortunately, it's a biased view. The patients in whom you use ECMO are the patients in whom the mortality is highest, right? So you don't expect the large majority of them to do well. We hope that more would do well. The problem is we're really limited in our understanding of how to really apply mechanical support to the PE population. We don't know, should we start it before we attempt to add advanced therapies? Should we do the advanced therapy first and then start it and kind of support them through the post-intervention period? How do we wean it? I think we're still in a very steep part of the learning curve for applying ECMO to PE patients. So we do it in patients that we either feel are too sick for any advanced therapy and we want to kind of buy time with anticoagulation until we can do something more definitive, or in patients who crash during advanced therapy. But as you can see, the MGH experience, the outcomes aren't terrific, and we really need more data.
Okay, well, I want to say thank you to Greg Piazza once again.
Thank you so much for having me.